In starting this basic course in electrocardiography, the first thing we want to do is to review some fundamentals. These are some of the things that you just have to know in order to be able to assess an electrocardiogram. Okay, one of these things, first thing I'm going to talk about is heart rate. And there are several different ways of determining heart rate, but what we want is a simple and practical method for doing this. All right, now if you take a look at an electrocardiogram, this is an example of electrocardiogram with the divisions appearing as I've roughly drawn. If you look at the top of the paper, you'll notice that there are small vertical marks. And these small vertical marks occur at 3-second intervals. So what we want to do is we want to count the number of beats in a 6-second strip. So let's say, for instance, this is where I've drawn, I'm drawing some QRS complexes, right? Now let's count these. 1, 2, 3, 4, 5, 6, 7, 8, almost 9. So this heart rate then would be 90. So what you do is you count the number of beats in a 6-second strip and just add a 0 on the end of it. Or, in other words, what you do is just multiply by 10, really. Okay, so that's probably the easiest and one of the most practical ways if you have a long enough strip. Okay, this is also very useful for determining heart rate in patients who have irregular rates. Okay, now, usually when we look at an electrocardiogram, we don't see a long 6-second strip. We just see very short strips after they're mounted. And if the rate is regular, it's helpful to remember this little guide. Well, here's our strip of electrocardiogram that I drew before. This is a little bit larger now. And we have these vertical strips, vertical lines occurring, which are divided then by 5 very small boxes. So you have boxes with dark lines in which there are boxes with lighter lines, and there are 5 of those within each one of these boxes. Okay, so the question I'm asking now is, what would the heart rate be if you had a beat occurring every one of these intervals? These really are 0.2-second intervals. What would your heart rate be if you had a beat occurring every 0.2 seconds? Okay, every one of those small divisions. Okay, that heart rate then would be 300. If you had a beat occurring every 2 divisions, then the heart rate would be 150. Every 3 would be 100. Every 4, 75. Every 5, 60. And every 6, 50. So this is a rough guideline then for assessing the heart rate. In most cases, you really don't need to know whether the heart rate is 55 or 58, and you can come close enough if you just use this rough guideline, providing the rate is fairly regular. If it's irregular, you have to do some averaging if you just have a short strip. Okay, so these are 2 then very simple and practical ways for determining heart rate. You can't spend a lot of time just determining heart rate because you have an awful lot of other things that you have to do in assessing electrocardiogram. Okay, the next thing I want to talk about is intervals. Okay, here is our normal electrocardiogram here. Okay, and what are some of the important intervals that we need to know in the electrocardiogram? Well, one of them is the PR interval. All right, let's make up a little table now. We have a PR interval, we'll have a lower limits of normal, and we'll have upper limits of normal. Right? So what's the lower limit of normal for the PR interval? 0.12. And the upper limit of normal is 0.20. Okay, these are two numbers that you just have to learn. You can't live without. These intervals are extremely important. You just have to sit down and memorize them. Okay, now there's an easy way to memorize this. Instead of remembering numbers, if you go back to our grid system that I described before, these are the two relatively dark lines, and which are separated by 5 small boxes, right? And we said that each one of these dark lines occurs every 0.2 seconds, assuming normal paper speed, which is 25 millimeters per second. So then, if each one of these dark lines occurs at every 0.2 seconds, then how long would this interval be in terms of time? It would be obviously 0.04 seconds. 0.04 times 5 would be 0.20 seconds. Okay, now, if we think of these intervals now in terms of boxes rather than in terms of just numbers, then we might have a visual way of helping to memorize or to remember what these are. So if we think that the lower limit of normal of the PR interval is 3 little boxes, where the upper limit is 5 little boxes, this might be a way that will help you to remember those numbers a little bit better. All right, so that the lower limit of normal, the PR, is 0.12, the upper limit is 0.20. So where does a PR interval go from on this electrocardiogram? Let's talk about that. Well, it goes from the beginning of the P wave. Does it go to the peak of the R wave, PR interval? No, it doesn't. It goes to the beginning of the QRS complex, PR interval. From the beginning of the P wave to the beginning of the QRS complex. Okay, and what kinds of things do we think about? I mean, in terms, suppose the PR interval was too short, what would we think about? Well, we think about such things as a nodal rhythm, Wolff-Parkinson-White. Okay, these are a couple of the diagnoses that you might think of offhand. And the upper limit of normal of the PR interval, if we had a PR that was more prolonged than 0.20, we have a diagnosis right away, right? And that diagnosis would be first-degree heart block. PR interval is greater than 0.20. You have a diagnosis of first-degree heart block. Okay, another important interval that we need to know then is the QRS duration. And what's the lower limit of normal for the QRS duration? There is none. There's no disease associated with too short a QRS duration. All right, then what is the upper limit of normal for the QRS? The upper limit is 0.10, or 2.5 little boxes, as we described before. So if the QRS is greater than 0.10, what are we dealing with? We're dealing with a conduction disturbance below the AV node, or we're dealing with a conduction disturbance through the ventricles. Okay. If the QRS is between 0.10 to 0.12, we're dealing with an incomplete conduction disturbance. This would be an incomplete conduction disturbance, whereas if the QRS is greater than 0.12, it would be a complete conduction disturbance. For instance, incomplete versus a complete bundle branch block. Okay, so the QRS duration then goes from the beginning of the QRS to the end of the QRS. And you can see here how the QRS is sloping down. This is very commonly seen in the electrocardiogram, and it's a little bit difficult to interpret exactly where the end of that QRS is. And it just takes some practice and some time until you can really assess whether a QRS is prolonged or not. But what you're really trying to do is you're really trying to just extrapolate this line right down to where it would intersect a baseline, the duration of the QRS. And in terms of asking whether the QRS is prolonged or not, you measure the longest QRS duration in the frontal plane leads. That's 1, 2, 3, AVR, LF. Okay, the longest duration in the frontal plane leads is the duration of the QRS complex. Okay, another important interval we have to discuss is the QT interval. And the QT goes from the beginning of the QRS to the end of the T. The beginning of the QRS to the end of the T. That's the QT interval. And what's the QT interval important for? What do we care about knowing whether the QT interval is prolonged or not? Well, it becomes prolonged in such things as electrolyte abnormalities, hypokalemia, for instance, certain drugs, and these are things that we're going to be talking about later. We'll talk about disturbances of repolarization. So what is the upper and lower limit of the QT interval? That's something we sort of went by here. It's heart rate dependent. Heart rate dependent. So what you have to do is you have to look at a table. And a table should be available in the notes that go along with this course. And you have to measure the QT interval and correct it for heart rate in order to see whether it's prolonged or not. Okay, so these are really the basic important intervals that you need to know. There's not that many numbers, there's only 3. 0.12, 0.20 for the upper and lower limit of normal for the PR interval, and then the QRS duration. But these are numbers that you just cannot live without. You just have to know this if you want to go on and learn how to read electrocardiograms. These are basic. Now there's another area here in the normal electrocardiogram that we haven't talked about, which I should mention briefly at this point here. And that is this area from the end of the QRS to the beginning of the T wave called the ST segment. And we're not interested in the ST segment in terms of whether it's prolonged or not. We're interested, of course, in whether it's elevated or depressed. So the question is then, what is significant elevation or depression of the ST segment? Okay, and this depends on the lead that you're looking at. Okay. So depression of the ST segment or elevation in the frontal plane leads. Frontal plane leads. That means 1, 2, 3 again, AVR, LF, those leads. 1/2 millimeter is all you're allowed. 1/2 millimeter elevation or depression of the ST segment. In the V leads, V1, 2, 3, 4, 5, 6, we're allowed more elevation. In the right precordial leads, V1 through V3, we are allowed as much as 3 millimeters elevation. 3 millimeters elevation can still be considered normal. Okay, in V4 through V6, you can have 1 millimeter elevation or depression before it becomes abnormal. Okay, so that's the ST segment. And as just to reiterate again, the ST segment is important in terms of its elevation or depression, and not so much in terms of its duration, though it is a little bit important in terms of duration too. When it comes to things like calcium levels, and we'll talk about that when we talk about disturbances of repolarization later on. All right, so now we've finished talking about intervals, important intervals. Let's talk next about a little bit about nomenclature, a little bit about the nomenclature of the QRS complex. And I just mentioned this at this point because I imagine that several of you are reading some books as you go along, and they describe this nomenclature. And in order to understand what they're talking about, it's good to know a little bit about this. So, suppose we have a complex that looks like this. Right? We call this a QRS. First negative deflection is a Q. First positive deflection is an R. Second negative deflection is an S. So that would be a QRS complex. If we just have a Q and then a positive, this would be a QR. Okay, fairly logical, but then we have this thing here. And this isn't completely logical, but what it's called is what? It's called a QS complex. Okay, it's not completely logical. I didn't invent the name, but that's the way it is. Okay, now, if we have just a positive deflection, we just call this an R wave. The first positive deflection is an R wave. So when people talk about tall R waves in the lateral precordial leads, we're talking about tall positive deflections, tall R waves. Okay, then we can have positive, negative. So this would be R, and then we said the second negative deflection is an S. So this would be an RS complex, and then we can go on and call it RS. And what would that be called? The second positive deflection. That would be called RS R prime. Right? So what would you call this one here now? Right, again, this would be called RS R prime. Notice the difference, though, in what I've written. This is a small r because the initial r is small, or this is the terminal r here is small, so we write a small r. Okay, I'm running out of room here. Let me come back to this side. Suppose we have this here. What would you call that? Let's just go through this now. This would be R, S, R prime, S prime, and R double prime. R double prime. So that would be the system. Okay. Well, let's just take one more example. What would you call this? An M-shaped complex. What would you call it? This would be R prime. Excuse me, there shouldn't be any prime by the first R. R prime. We don't go to the negative side, so we don't get an S. We just call this an R prime. All right. Well, let's move on now, and let's review the taking of a normal electrocardiogram at this point. Now, many of you have taken electrocardiograms, but there seems to be a little inconsistency in some of the details, so it's just worthwhile reviewing that at this point very briefly. Here's a patient here. Here's the sternum, and here's the clavicle, and here's call this the fourth interspace and the fifth interspace, right? So what I'm talking about really is the placement of the precordial leads. I think no one will make a mistake in putting the arm and leg leads in the right places. So V1 would be located fourth interspace to the right of the sternum. V2, fourth interspace to the left of the sternum. Now where do we put V3? Right, it goes halfway between V2 and V4. And we know that V4 is in the mid-clavicular line in the fifth interspace. But we don't take V4 before we take V3 because we'll confuse the technician or whoever has to mount this. So we put our finger on the spot where we think V4 ought to be, and then there's the red suction cup mark from V2, and then right in between there should be V3. Then V4, as I indicated. Now where do we put V5? V5 goes in the anterior axillary line. In which interspace? No, it doesn't go in any interspace, what you do is you go out in a straight line. In a straight line, because you see the ribs are curving around. What you do is you go out in a straight line laterally when you're recording V5, and the same thing for V6. You go in a straight line laterally, and this is the mistake that people commonly make. They curve around the interspace. So this is in the anterior axillary line, and V6 is in the mid-axillary line. Okay, so that's fairly straightforward. But it's important that everyone try to record the electrocardiogram in exactly the same way. Otherwise, we might have apparent changes which are really not due to what's going on in the patient, but really just due to misplacement of the leads. All right, now let's talk a little bit about axis derivation. This is another very important routine thing that you will do in the interpretation of every electrocardiogram, is determining axis. And there are ways in which you can determine axis very accurately. For clinical purposes, this is really not necessary. So what we want is a reasonably accurate method which can be done accurately, relatively accurately, and quickly. You can't spend a lot of time figuring out what the axis is. So everybody knows what that animal is. That's Einthoven's triangle, right? And it's set up so that we're going from negative to positive. So this would be lead 1, negative to positive. Lead 2, negative to positive. Lead 3, right? And if you're like me, I always used to get lead 2 and 3 mixed up. I could never remember which one on which side. Well, let's see if we can straighten that out or get a way to remember that. Okay, now what we're going to do is we take out lead 1 and just put it here. This is lead 1, negative to positive. And if we have negative to positive, we'll just draw an arrow at the positive end, right? Okay? Now we'll do the same thing with lead 2, except instead of putting it down here, as this triangle is, we'll run it right through a central point, right? So we're superimposing them instead of forming a triangle. So this would be lead 2. And then lead 3 would do the same thing. Okay, so this is the directions of the 3 bipolar leads then. And this you shouldn't get confused with. Just remember, it always goes around clockwise. 1, 2, 3, right? 1, 2, 3, sweeps around clockwise. You shouldn't have any problem then with mixing up lead 2 and lead 3. Okay, so these are the bipolar leads. Now let's figure out where the unipolar leads are going. Okay, the unipolar leads bisect these angles. And they're easy to remember because they tell you where they're going. AVR goes to the right arm. AVL goes to the left arm, L left, and AVF, F, means goes to foot, right? So that should be easy to remember. And just remember, they bisect each of these leads. Okay? So this would be AVR going to the right arm, AVL going to the left arm, and AVF going to the foot. And these are the positive end of each of these things. Okay, so those are the 6 funnel plane leads then, which we will use for deriving axis. Now, if we just take AVF and continue that on the negative side, and the same thing with AVR, extend that through, and take AVL and extend that all the way through too in a straight line, we have the composite diagram, which covers just about every possible direction. And most of you are familiar, have seen this diagram in one form or another, if you've looked at any EKG book. All right. Well, now let's set about trying to determine axis. Okay. The rule for determining axis, there are several ways you can do it, but let me just go over a way that I recommend as being simple and relatively quick. Is what you do is you take a look at the electrocardiogram, 1, 2, 3. You just look at the frontal plane leads, 1, 2, 3, AVR, L, and F. And you look for the lead, which is isoelectric. By isoelectric, we mean equally up and down, or the point is that it has to be the same area above as below. That's the isoelectric lead. And usually every cardiogram, we can find one lead which comes the nearest to being isoelectric. We may not find a perfectly isoelectric lead. In some electrocardiograms, every lead looks like this. Every lead is isoelectric. And if you see something like that, your axis is what they call indeterminate. You can't determine the axis, obviously. So this is called an indeterminate axis. If every lead looks something like this, some might be negative and then positive. But they're all isoelectric, is the point. Okay, those are relatively rare, and there are implications, diagnostic implications when you see things like this. Certain types of infarctions will look like this. Patients with chronic lung disease will occasionally have indeterminate axes. Okay, but going back to this situation, as I said, most every electrocardiogram will have a lead which is most nearly isoelectric. Okay, so we look for this lead. Okay, let's just say, for example, that it's lead AVF. Let's see, we look at an electrocardiogram, we look and see AVF is isoelectric. Okay, now what we want to find out is what the mean axis is doing. Now, the point is that the mean axis runs directly at right angles to the isoelectric lead. The mean axis runs directly at right angles to the isoelectric lead. So we took our example, we said it's isoelectric in AVF. Now we said our mean axis runs directly at right angles. So what's at right angles to AVF? Lead 1 is at right angles to AVF, right? And we could be either going this way or we could be going this way. The axis could be either be going directly out to the left or directly out to the right. We don't know which. Okay, so we found our isoelectric lead, and then we say to ourselves, well, the mean axis then is either going towards lead 1 or it's going 180 degrees away from lead 1. Okay, so we've narrowed it down to two possibilities. So the next thing then we do, after we've said that, is we go back to our electrocardiogram, and then we would look at lead 1. We look at lead 1. Okay, let's go back to make believe we have an electrocardiogram. We look back here, and suppose lead 1, back on our electrocardiogram, is positive. Then our axis would be going in the direction of lead 1. If lead 1 was negative, then the axis would be going, in other words, if lead 1 was positive like this, the axis would be going this way. If lead 1 was negative, the axis would be going this way. Okay, let's just assign numbers. The numbers here are, this is called 0. You're starting from here, 0. And as you go around this way, well, let's go around this way first, because this is plus 30, plus 60, plus 90, and this goes around to 180. And here we're going around this way, minus 30, minus 60, minus 90, and this minus 150, etc. So these are the numbers. So let's just take that example again. We look at our electrocardiogram, we're isoelectric in AVF, right? Now we say to ourselves, isoelectric in AVF. That means that the mean QRS is running at right angles to AVF. What lead runs at right angles to AVF? Lead 1, okay? So we go back to our electrocardiogram. We say, well, what does lead 1 look like? Lead 1 is positive on the electrocardiogram. Let's say lead 1 was positive. So then our axis is 0. If lead 1 was negative, then our axis would be 180, right? Well, let's just take a few examples and see if we can get this to settle in, if you're not familiar with it. Let's just take a few examples and say, let's make believe we have an electrocardiogram here that we're looking at. Electrocardiogram is isoelectric in lead 2. Let's say we're isoelectric in lead 2, this lead. Okay, so next thing I ask myself is, what lead runs at right angles to lead 2? And I look over here and I can see this is the isoelectric lead. 2 goes like this, and at right angles to that is AVL. Okay, so I go back to my electrocardiogram and I say, what does AVL look like? And it says AVL is negative, let's just say. AVL is negative. So it's not going in the direction of AVL, it's going in the direction away from AVL. So my axis then would be minus 150. Okay, let's just take another example. Suppose this electrocardiogram that I'm now looking at is isoelectric and lead 1. Okay, isoelectric and lead 1. What lead runs at right angles to lead 1? Well, AVF does. Okay, so I go back to my electrocardiogram and I look, what does AVF look like? AVF is positive, let's say, in this electrocardiogram that I'm looking at. Okay, so my axis then would be minus 90. Okay, take another example. New electrocardiogram, isoelectric and AVR. Let's say we're isoelectric and AVR. Here's AVR. What lead runs at right angles to AVR? Lead 3 runs at right angles to AVR, right? Okay, let's go back to our electrocardiogram and look at lead 3. Lead 3 is negative. That means that the QRS is not going this way, it's going back this way. So we have an axis then of plus 60. Okay, well those are several examples, and I think to those of you who are not familiar with this, if you just sit down and just look at a dozen or so electrocardiograms, go through the method, this will settle in very quickly and be very easy to do. Okay, so now that we've gone ahead and we've derived the axis, let's make a little diagram here. Okay, and this is, again, 0. This is minus 90. Excuse me, I think I went in the wrong direction before. This should be plus 90. It's just backwards from what I did before. This is plus 90, this is 180, and this is minus 90. Okay? It's just the reverse of what I did before. Okay. Given this too often. Okay, then here we have a minus 30. Okay, that would be minus 30 instead of plus 30, as I indicated before. Okay, so now suppose you have a QRS that falls, let's say, into this quadrant. That be all right? Yes, that's the normal, this is the normal quadrant. Okay, suppose our axis fell into this quadrant here. We would call this left axis deviation. If it fell into this quadrant, right axis deviation. Well, what would we call it if it fell into that quadrant, this quadrant up here? Well, they call this marked right, for want of a better term, I suppose. This is called marked right axis deviation. But this is a very important quadrant. We don't see that many patients who actually have axes that go up in this direction. You can have patients with severe right ventricular hypertrophy who are continuing up in this direction. You can have patients with severe left ventricular hypertrophy going in this direction. Conduction disturbances sometimes, infarction sometimes. But the thing that is really, I think, helpful to remember is if you have a confusing electrocardiogram you can't really make anything out of, and you see an axis that's going straight up in the air or over in this direction, you should think of one thing. What? Pulmonary disease. Pulmonary disease. Frequently, patients with pulmonary disease have these strange axes. They go straight up or slightly into or into this marked right axis deviation quadrant. It's a worthwhile, useful thing to keep in mind. Okay, so these are the axes. And so instead of defining an axis in terms of degrees, which is certainly valid in doing, you can say, normal axis, left axis, etc. All right. Now the next thing that I want to cover is a normal R wave progression. This is a very simple and easy thing, but it's one of the things that we're going to be going through when we look at every electrocardiogram. We're going to be looking at the normal R wave progression. This is extremely important when we're considering the possibility of myocardial infarction. Okay, so let's go then through normal R wave progression. In normal R wave progression, we're talking about changes in the electrocardiogram in the V leads, V1 through V6. You look at V1, looks like that, V2, V3, V4, V5, and V6. Something like that. Okay, and what you'll notice here is this R wave, this is V1, V2, V3, V4, V5, V6. So what you'll notice here is this R wave here is getting progressively taller and taller, generally until you get around V4 or V5, and then it gets smaller again. But you'll notice there's a nice, smooth, relatively smooth increase in the height of the R wave till you get around V4, and then there's a gradual decrease again. This is normal R wave progression. And when there's an abnormality of the R wave progression, this has certain implications, particularly, as I said, myocardial infarction. So in every tracing, we're going to be looking at normal R wave progression. In other words, we'll be using this diagram later on. If we were to make a plot, we say this is V1, this is V6, and this is height to the R. We'll say in V1 it's about this tall, and then it's gradually getting bigger till around V4, and then it's gradually decreasing again. So this would be a plot then of what I've just drawn for the normal R wave progression. Okay, any question then about normal R wave progression? Okay, well there's just a few other things here that I'd like to cover before we finish. And one of them is T waves. And the second thing is position and rotation of the heart. Okay, T waves. Now, as a rough rule, we can say in a frontal plane, when we're talking about the frontal plane, leads 1, 2, 3, AVR, LF, that the T waves should generally be upright in every lead except for AVR. Now there are certain exceptions to that, and I'll talk about that when we talk about positions to the heart, but as a rough overall guideline, every lead in the frontal plane should show an upright T wave, perhaps except for AVR. But we'll talk about exceptions. Okay, in the V leads, which I drew just a minute ago, sorry I erased it. Okay, that's V1 through V6 again. 1, 2, 3, 4, 5, 6. Okay. The T wave should be upright in every lead, except for V1. And it doesn't matter what it is in V1. It can be negative, it can be positive, or it can be biphasic. It doesn't matter. But from V2 on, this is in the adult. Children, different story. But in the adult, from V2 on, the T wave should be upright in every lead. Okay. Now let's talk a little bit about some principles of T waves, first of all. In the frontal plane, going back to the frontal plane, leads 1, 2, 3, AVR, LF. We said that the T wave should be upright in every lead, perhaps except for AVR. Now, a principle to be considered is that if you have a QRS vector that's going in this direction, your P wave vector, or your axis, we're just talking about axis at this point, your T wave and your P wave axis should be going in roughly the same direction. They should be the T wave should be within 60 degrees of your QRS. This means when you look at an electrocardiogram, what you should expect is that everything is going in the same direction. In other words, if you see an upright P wave, you should see an upright QRS and upright T, generally speaking. If you see a negative P wave, your QRS should be negative. And your T should be negative. And also, if your P is biphasic, your QRS is the same, and the T should be biphasic. What this means is that all of the vectors are traveling in the same approximate direction, right? It's when you see a discrepancy that there's something abnormal. You can't say what the abnormality is at this point. You just say there's something abnormal. There's either something wrong with this P wave or there's something wrong with both the QRS and the T. But the point is that roughly all of these vectors should be going in the same direction. Well, then let's talk about the exception. Suppose we have a mean axis of the QRS which is going like this. Suppose we have a mean axis of the QRS that's 0 degrees. We've determined it, and it turns out to be 0 degrees, right? And our principle was that all of these axes should be going in the same direction. The T wave should be going this way. The P wave should be going the same way, okay? So let's say they are. Okay, now, lead 3 in that situation, which is over here, you'd expect everything to be negative in. If you're looking at this vector, this mean QRS, from this side of the, from this point of view, everything here is going away from lead 3, so you'd expect everything here to be negative. Right? So in this situation, we have an exception to the rule. When you have a heart with an axis that's going over at 0 degrees, it's all right to have a negative T wave in lead 3. Okay? Remember before we said the T wave should be upright in every lead except for AVR. Okay, the same thing holds when you have an axis which is going in this direction, right? It's all right then to have a negative T wave in lead AVL. So the exceptions to the rule are then, if you're dealing with a vertical heart, and now we're talking a little bit about position, we're dealing with a vertical heart. This would be a heart that has a QRS axis that's going straight down. That would be a vertical heart. Dealing with a vertical heart, it might be all right to have an inverted T wave in AVL. If we're dealing with a horizontal heart or a horizontal axis, it might be all right to have an inverted T wave in lead 3. Okay, so that brings us to position now. Okay, when we talk about position of the heart, we're talking about position in the frontal plane. This is in the frontal plane. That's 1, 2, 3, again, AVR, L, F. So this system, 0, 90, minus 90, 180. So, as we said just a few minutes ago, if we have an axis going out this way, we call that position. The position of that heart would be horizontal. So this would be horizontal. If we have an axis going this way, we'd call the position of that heart, or the axis of that heart, to be vertical. Okay, that's pretty obvious and simple. But it's important, particularly in terms of implications about normal and abnormal T waves. The position of the heart has to be considered. Okay, now talking about rotation. With position, we're dealing with the frontal plane, as I indicated. With rotation, we're dealing with the horizontal plane, the V leads. All right, so let's make a little diagram here. Let's say this is a patient here. These are his feet. So he's lying. These 3 patients here are lying on their backs in bed, and this is just to give you a perspective of the way to look at the patient when you're talking about rotation. Okay, and here's your clock. Let's say there's a clock over his head, right? Now, As I said, when you're talking about rotation, you look at the V leads. And what you look for in the V leads is you look for the isoelectric lead. Now, what's normally the isoelectric lead in the V leads? Right, it's about V3 or V4. V3 or V4 is normally the isoelectric lead. So by isoelectric, again, we mean equally up and down. So the isoelectric lead generally goes out about in this direction. Right, this is our normal patient, and this is what the isoelectric lead should look like. And here's our clock, 12 o'clock, 6 o'clock. So we're normally going at about, let's say, 1:30, let's say 2 o'clock, for the sake of argument. Okay, now, let's say that we're dealing with clockwise rotation. Now, in clockwise rotation, the position of our isoelectric lead has shifted clockwise. So which way is clockwise? Here's 12, 6. So we've gone from this position to this position, clockwise. So instead of our isoelectric lead occurring in V3, it's now occurring in clockwise rotation. This is clockwise. It's occurring out in V6. So it becomes isoelectric in V5 or V6 now. So this would be an example of clockwise rotation. Counterclockwise rotation, going just the opposite direction. We started off here. This is normal. And this patient, he's isoelectric in lead V1. Isoelectric in lead V1. Shifted counterclockwise. So this would be counterclockwise rotation. So our isoelectric lead has shifted from a normal position, which is around V3 in clockwise rotation, out to V6. In counterclockwise rotation, it shifted from a normal position in a counterclockwise direction towards lead V1, and the isoelectric lead then may be in V1. Okay, well that covers then some of the fundamentals that we are going to need to know in order to evaluate, in order really to go on. Now, some of these things are more important than other things. So let me just emphasize the things you really just have to know in order to be able to interpret an electrocardiograms. One of them, of course, is heart rate. You can't waste a lot of time determining heart rate. You have to do that quickly and easily and approximately correct. The intervals, extremely important. Can't live without learning intervals. Nomenclature, not that important. Taking the EKG, that everyone knows to know how to do that, but that's not that crucial for reading it, certainly. And then another important thing that you have to learn is axis. Axis just has to be known. Another very important point. Normal R wave progression. This is something we're going to be looking at in every electrocardiogram. You just have to know the normal R wave progression. T waves, should know what a normal T wave is and what an abnormal T wave is. Position and rotation, this is something that's nice to know. It's really not that vital or important. Okay? So the important things to summarize then again, heart rate, intervals, axis, derivation, normal R wave progression, and T waves.